Welcome to this session, TB infection control, too fast, too slow, just right. My name is Enos Masini from Kenya. My co-chair is Kari Tuda from Switzerland. We will start off for the presentations. Just to remind the presenters that they have 8 minutes to do the presentations, then we allow 3 minutes for a couple of questions before we move to the next, and kindly request them to stick to time. So our first presenter is FAST, a new strategy for infection control. Welcome, Paul. You have 8 minutes for the presentation.
How long?
And eight.
Good afternoon. This is Dr. from Bangladesh. I'm working with IRD Bangladesh, first is actually refocused, intensified administrative approach, surveillance with rapid diagnostics. FAST stands for finding cases actively by cough surveillance and rapid diagnostics, separating safely and treating effectively based on rapid drug susceptibility testing. It based on the hypothesis is that unsuspected and undiagnosed TB or drug resistant is eliminated from hospitals and clinics. This should be no one able to transmit infection again. Objective of the FAST, the main objective of the FAST strategy is rapid identify unsuspected TB or MDR TB cases and put them effectively treatment to prevent the further transmission of disease. In Bangladesh, we took some strategy, and the method is, the first strategy was introduced at National Institute for Disease of Chest and Hospitals, NIDCH in Dhaka, Bangladesh in 2013. Actually, this NIDCH is the biggest chest disease hospital in Bangladesh. And although this is chest disease hospital, but also known as the biggest TB hospital in Bangladesh. Later, it was scaled up to the Bangladesh Institute of Research in Diabetes, Endocrine and Metabolic Disorder, BARDEM. This is the biggest hospital for diabetes. And also, we scaled up it to the Chittagong Chest Disease Hospital. This is the second biggest chest disease hospital in Bangladesh. Sputum of all newly admitted cases in those 3 facilities were tested by gene expert. The patients were divided into 2 groups. One group contained TB patients but not known MDR, to screen the MDR cases among them. And another group is other lung disease but not known TB cases, to screen from TB or MDR TB among that group. How we implemented the FAST in institutions? System development first. So participatory approach to develop system and tools. So small SOP is developed in participatory approach, and some tools are developed along with the NTP, working with the NTP, WHO, and other stakeholders. Facilitated administrative decision and incorporating FAST to the overall facility of infection control plan. So this was some administrative change we made. Integrated management of FAST activities by existing staff. Development of FAST screening algorithm, development of recording and reporting registers, M&E system, assignment of staff for cough monitoring, recording and reporting, monitoring and reporting. Actually, we didn't want to impose, recruit new staff, or we were looking at the cost effectiveness of this FAST project in Bangladesh. So we didn't recruit any new staff, so this is just simple administrative change and task allocation to the other staffs. And later capacity was developed to the doctors, nurses, and laboratory technicians who were working in the hospital and the laboratory. So the first implementation strategy here, very simply I'm showing here. So first is all the admitted patients in the hospital, their sputum was collected by the nurses, and this sputum was sent to the laboratory, I mean the NTRL, firstly. So there, after doing expert test, if someone diagnosed as TB, they were sent to the TB ward. If someone not diagnosed as TB, they remain in the same ward. If someone diagnosed as MDR TB, they are sent immediately to the MDR TB ward, and treatment were initiated immediately. So a result of FAST from July 2014 to June 2015. Although we started in the 2013, but it was pilot, and the pilot data result is separated. So afterwards, when we scale up to the 3 facilities, this is the altogether result. So as I have said, that there are 2 groups. One is non-TB, another is TB. Among TB, again, so from current TB patients, we tested 682 patients sputum, and we found 31 reef-resistant patients. And other lung disease patients, we tested 4,916 patients sputum and found 488 TB patients and rifampicin resistance 42. Other lung disease with history of TB. Before it was, this one is actually, this other lung disease of patients without TB history, and now this is with, again with TB history. So with TB history, 1,112 patients were tested, and among them 245 found to be TB and 16 rifampicin resistance. And altogether, I mean all patients categories, so total 6,710 patients tested, and TB diagnosed 733 and rifampicin resistance diagnosed total 89. So this is the highlight. So among reef-resistant MTB among TB, so those who were not suspected as MDR TB, but they found to be reef resistance after testing by gene expert, 4.55%. And from other lung disease, TB who were even not suspected as a TB, but 9.9% of them diagnosed as TB. And reef resistance MTB among other lung disease, even not diagnosed as TB, from them we diagnosed some MDR TB also. This is 0.85%. And patients with history of TB, but recently they are not suspected as TB. So from among them, 23% comes as a Mycobacterium TB positive. And rifampicin resistant MTB among patients with TB history is 1.5%. So totally, if summarize, we can say that 733 TB patients and 89 drug resistance TB cases would have gone unidentified and untreated unless FAST is not there, and they will be continuing spreading TB and MDR TB infections. So what lesson we learned from that things? First is effective approach to increase early detection of unsuspected TB and MDR TB cases. Simple to integrate with existing management system. Essential for implementation with existing staff with minor adjustment of the task. Minimal system alteration to practices around the diagnostics and treating patients. Easy to scale up with minimal disruption of ongoing activities. In conclusion, I want to say the first strategy is simple prioritize and infection control activity by placing increased emphasis on administrative infection control. Rapidly diagnosing and treating TB patients is the best way to reduce spread, especially from the healthcare workers who are at risk of infection due to routine direct patient care. So not only the patient to patient, also from the health workers. The first strategy can be used to diagnose TB or MDR TB with a variety of healthcare and congregate setting, as we did in other, not only TB ward or other wards also, other hospitals also. So thank you.
Thank you very much, and we'll take questions at the end.
Okay, thank you. The next presentation is from Nick McCrish from the United Kingdom, and it's on comparison of indoor contacts in Zambia and South Africa suggests infection control intervention targeting should be informed by local data. Welcome.
Thanks. So we currently have very little idea where the majority of MTB transmission occurs in high-burden sub-Saharan African countries. Molecular studies suggest that in these settings, less than around 10% of transmission occurs in people's homes. Occurs between household members, sorry. So most transmission must be occurring outside people's own homes. At present, the use of infection control measures as a way of reducing transmission is quite limited and rarely extends beyond clinics or homeless shelters. This is despite the existence of some very effective infection control measures. Installing upper room UV lighting in TB clinics reduced transmission to guinea pigs by around 70 to 80%, And while not suitable for all types of location, these kind of devices could still be much more widely employed than they currently are. Improving ventilation can also be extremely effective at reducing transmission. And something as simple as a campaign to encourage people to keep doors and windows open in high-risk public buildings could potentially be highly effective. To maximise the impact and cost-effectiveness of these kind of interventions, we need to be able to identify the types of locations that are important for overall transmission. One way of doing this is to use reported contact data to identify the locations where people spend the most time and come into contact with the most other people. As part of this need to understand transmission, I determined contact patterns in urban locations in Zambia and Western Cape, South Africa, and I compared the results between the two settings. The data I used was from the CODA study. Previous analysis of some of the data by Pete Dodd looked at close and casual contacts by men and women. In this study, I analysed the same data to look at the locations where these contacts occurred. 3,206 respondents were interviewed using a structured questionnaire about the places they visited on the day before the interview. For each building they visited, they were asked what type of building it is, how much time they spent in the building, how many adults and youths were present, and how many children were present. And all the results I present are weighted to take into account the sampling method and also the day of the week of the interview. So now on to the results. The two graphs at the top show the proportion of respondents who reported visiting different types of building and the mean duration of visits. On the bottom, the graphs show the mean number of other people present during visits. Adults and youths on the left and children on the right. The blue bars are for Western Cape and the red bars are for Zambia, and the darker shade indicates there was a significant difference between the two countries. So you can see from the graphs that overall patterns of contact were quite similar between the two settings. There are some differences, however, and I'd like to draw your attention to two types of building in particular, churches and indoor workplaces. Visit durations, the number of adults and children present, are quite similar for both types of building in both countries. There are very large differences between the two settings in the proportion of respondents who reported visiting that type of location on the day before the interview, however. Church visits being far more common in Zambia and visits to indoor workplaces being more common in Western Cape. These graphs now combine some of the data I presented on the previous slide, and they show two measures which give a better indication of the relative importance of different types of location for overall transmission. On the top line, the graphs show the number of people met by respondents in each location, and on the bottom line, this is combined with data on the duration of time spent in locations to give the overall number of contact hours between respondents and other people at each location. Overall, two types of locations stand out most clearly as the locations where most contact occurs, churches and workplaces, with churches being particularly important in Zambia and workplaces in Western Cape. And this is true both for contact between adults and youths, and also for contact between adults and children. For both countries, the relative importance of workplaces increases when visit durations are taken into account, so the bottom graphs, which is to be expected as people tend to spend longer in workplaces than they do in churches. There are few limitations of the methods we used to collect the data. Data were reported by participants rather than directly observed, so it's possible that respondents over-reported visits to, say, churches and workplaces and under-reported visits to bars. I haven't included contacts on public transport in my analysis as comparable data were not collected, and therefore I can't say anything about the role of public transport. And finally, data collection was retrospective. However, respondents were only asked about the day before the interview, and so recall bias is likely to be minimal. In addition, our findings for Western Cape were quite similar to findings from a similar study in a nearby location, which collected the data using prospective methods. So what studies of contact data such as this one do is they tell us where people spend their time and where they have a lot of contact with other people. What we're really interested in is where MTB transmission occurs. And collecting and analysing this kind of social contact data is a useful and necessary first step, but it doesn't give us the whole picture for three main reasons. The first is that buildings vary in their suitability for transmission, and all else being equal, the risk of transmission may be far higher in a badly ventilated, very crowded bar, say, than in a well-ventilated shop. A qualitative study conducted in Cape Town suggests that churches there may be very suitable locations for transmission, but unfortunately it didn't look at indoor workplaces. Some interesting work has and is being conducted in this area, using carbon dioxide concentrations as a proxy for rebreathed air, or even directly measuring MTB levels in the air. So our understanding of building suitability may start to improve in coming years. The second reason is that some types of location will be visited more frequently by infectious and/or highly susceptible people. So the obvious example is clinics, and ART clinics in particular. So although my data shows that very little contact occurs in these in clinics in either country, this may greatly underestimate their importance for transmission. There's also a second, more subtle version of this point. People who have a lot of contact with other people will have a high behavioural susceptibility to infection. If they then go on to become infectious and continue to visit the same kinds of location that put them at increased risk of infection, then they will amplify transmission at those high-risk locations. Finally, even in high-prevalence settings, the proportion of people who have active infectious TB disease at any one point in time is low. And on top of that, there's lots of variation in infectiousness, even between people with smear-positive disease. And in addition, there's lots of variation in susceptibility to infection and disease progression. What all of this means is that rare chance contacts between highly infectious and highly susceptible people may be very important for overall transmission. These contacts are most likely to occur in the places not where the amount of contact time is highest, but where different people are met on each visit, public transport, for instance. So to conclude, patterns of contact vary by setting, which means that infection control measures in congregate settings need to be informed by local data. Despite the difficulties in translating contact data into transmission risk, my results suggest that churches may be important infection locations in urban Zambia, and indoor workplaces may be important in Western Cape, and the potential for targeting infection control measures at these locations should be considered. More widely, we need to develop a better understanding of where transmission occurs in high-burden settings to allow us to get the greatest benefits from both new and existing infection control measures. I'd just like to acknowledge a few people, particularly the Gates Foundation, that funded this work and the study participants. Thank you.
Next we have Rajesh, sorry, I don't want to mispronounce your name, is going to be talking to us about TB infection control assessment at high-burden antiretroviral therapy centers under the THEIS project in India, a country experience. Are they not? There we go.
Good afternoon, ladies and gentlemen. You are aware tuberculosis is most common opportunistic infection among people living with HIV. India is having second highest burden of TB and HIV cases globally. There are several documented studies on risk of transmission of TB infection in healthcare settings, specifically in the HIV care settings in India. India's HIV program has been successful in scaling up the antiretroviral treatment centers to a large scale from 69 in 2007 to almost 525 centers. But then unfortunately, the airborne infection control assessment was not incorporated within the initial assessment of ART centers. The National Airborne Infection Control Guidelines in India, April 2010, and the National Framework for TB-HIV Collaborative Activities in India, they recommend about the airborne infection control in the ART settings, but there is still a practical gap in implementation of those guidelines. So this was a massive intervention, public health intervention, where 30 high-burden ART centers, which approximately covered 70% of the total TB-HIV co-infected cases in India, across 5 high HIV prevalent provinces were selected for assessment. 30 teams with team members who were actually trained in airborne infection control and assessment of airborne infection control did the assessment for 2 days in each of these ART centers during October to December 2015. There was an airborne infection control format and tools were used for doing the assessment. So this airborne infection control format had 2 components, one of which is actually having 50 questions which were having administrative as well as environmental and personal protection measures related questions, as well as questions related to surveillance and monitoring and reporting as well. There were open-ended questions as well, and key observation and recommendations were also noted down for each and every center. I will not be able to share the entire report because of the paucity of time, but some summary observations and results are shown here. So, the facility level infection control committees existed in almost 70% of the ART centers, but the problem was only 53% of the facilities had the infection control committee meetings regularly. There was actually difficulty in documentation by the centers. Only 36% had infection control plan available in written form. The nodal officer for the infection control activities, there was gap in training of the key staff, and infection control education training on specifically infection control, airborne infection control, was done only in 37% of the cases, centers, and there was actually lack of training material specifically for airborne infection control, though it had some documentation on training material on swine flu and other diseases. Signages were displayed in 50% of the cases. That was good thing. One was actually even one of the good thing we found that the practice of fast tracking of the chest symptomatics was observed in almost 70% of the 73% of the facilities, and majority of it is done by the staff nurse of the antiretroviral treatment centers. So there was constraint seen in the identification of TB cases among the healthcare workers. Only 6% facilities had some focal point to collect the information on TB infection among the healthcare workers. Active screening for TB for the ART staff was lacking. We saw the sample collection for TB diagnosis had very well ventilated in majority of the centers, like 56% had a center which was well ventilated. Surgical masks for the patients were found in 47% of the facilities. There was definitely a deficit in N95 respirator availability in majority of the centers. The key observations, actually, if you see the major observation in almost all the centers was as the ART centers are mostly centralized in India, and with a structured pattern of design of the ART center, you could see that the center had crowded medical OPDs. There was a long waiting period in the pharmacy counters as well as the other areas. Fast tracking by staff force nurse using 4 symptom complex was seen efficiently in majority of the centers. Actually, they are using stamps for cough, fever, weight loss and night sweats, which is clearly demarcated in each and every center. But this fast tracking was ultimately not seen in some of the counters like the pharmacy counters, and there was overcrowding seen at specific centers like the medical officer centers, and that's why the waiting period of patients within the ART center was high. Minimal cross ventilation was seen as the ART centers, which were provided a space, were actually having difficulties in the design, wherein there was no enough cross ventilation seen. And even if cross ventilation was there, sometimes there was a barrier in cross ventilation airflow, and with the banners, with almirahs and other spaces were occupied by the unutilized material also. So finally, it is concluded that we need to prioritize the airborne infection control activities and measures within the HIV care facilities also, and there is need for high administrative commitment for that activity at each and every level. Findings like meeting of infection control committees, which help in identifying the problems and bottlenecks at each and every centers. Training is a key area where improvement is needed, and provision of masks for the patients as well as N95 respirators for the health staff is very much required at the centers. Resource allocation and sustainable funding support to ensure that the airborne infection control activities are implemented practically in the HIV care settings is very much required at each and every level, and follow up on the activities. There should be one focal point who can be actually follow up or do the follow up for all the recommendations which are provided for the assessment, and regular monitoring for airborne infection control activities is required to ensure that these activities are implemented, including healthcare worker surveillance of the staff, which is most critical when it comes to infection control. So thank you very much. I acknowledge the ministry, the WHO, and CDC India. Thank you very much.
So we're doing well on time, so it looks like we'll have a nice time for discussion after. The next presentation is with Anneke Peters from South Africa on infection control and MDR decentralized sites in South Africa. Anneke.
It's a privilege to be here, and I'm going to present on our decentralized model and especially on the infection control. And I'm going to give a little bit more. We don't do recommendations, we do implementation. So I will just share with you some of the things that we've done. So my outline will be the background, the decentralized MDR-TB care in South Africa, the objectives, the methods and approach, findings, and then interventions and the acknowledgement. Now, I think first of all, I need to say to you that we are an internal partner of the Department of Health, JPS Africa. So all activities that we do is in collaboration with the National Department of Health. And we receive our funding from Global Fund via the Department of Health. Now, South Africa has 9 provinces, 52 districts, and 262 sub-districts with a population, with a population of about 55 million people. Now, South Africa has an estimated incidence of 450,000 cases of active TB, with about 66% of these who is co-infected. We know that South Africa also has the highest prevalence of HIV worldwide. South Africa MDR-TB burden ranks under the highest in the world, with about 11,500 patients on treatment. I'm not saying diagnosed, I'm saying on treatment. South Africa Department of Health implemented their first MDR-TB management program in 2000. And all MDR-TB patients were hospitalized for at least 6 months after starting treatment or until they convert. I don't know. Oh, can you just take it? Thanks. A clinical audit of drug-resistant TB services were held, and together with a WHO-led review of the TB program, it was revealed that there was a delayed initiation of treatment, inadequate bed capacity, poor infection control and prevention in hospitals, poor adherence to treatment. And in 2011, the South Africa Department of Health implemented their guidelines and policies for the decentralization of MDR-TB management. Now, at that stage, we had the Tugela Ferry outbreak, the XTR outbreak in 2006, and we also had, at some stages, up to 3 to 6 months delayed treatment because there was just no bed space for the patients. So part of the decentralization, there are specific requirements that needs to be in place before any facility can start with the decentralization process, where from infection control is one of them. So basically what we do, we have an assessment tool. We will go into the facility, and then from there on, we will assess the whole facility, and then depending on the outcome, we recommend that that facility will start with MDR-TB treatment on site. So under the infection control, the most important things are the well-ventilated waiting rooms, well-ventilated consulting rooms, UVGI lights and extractor fans where needed, and then your respiratory protection, surgical mask and N95 respirators available. Now, South Africa Department of Health subcontracted JPS Africa to support the decentralization of the MDR-TB, and we are also the first country worldwide that started with nurse-initiated MDR-TB treatment as part of the decentralized process. Now, the objectives of this specific study was to assess the ICP practices and potential decentralized MDR-TB facilities, to identify strengths, challenges, and gaps in ICP in potential MDR-TB facilities, and to prioritize actions and resources to ICP in decentralized MDR-TB facilities. The hospital that you see there is the Tugela Ferry Hospital, where the XDR-TB outbreak was. So we did a cross-sectional descriptive study together with the Provincial Department of Health and the South African National Department of Health. Priority sites for assessment were identified based on the MDR-TB burden and absence of decentralized units in a specific district. Now, eventually, they want at least one decentralized site within each district, but the expansion were much faster than expected. In the new round, they want at least 2 primary healthcare facilities per sub-district to have nurse initiation. A standardized ICP assessment tool was developed for the data collection on various infection control requirements according to the WHO standards, and then joint ICP assessments were conducted with the Department of Health, the districts, the provinces, and then also the Council for Scientific and Industrial Research, that they have a department that's specializing on infection control, especially on infrastructural infection control. So the key focuses areas that we did was the availability of ICP guidelines and policies, active ICP committees. I'm saying active, not committees, because what we did was that you need to at least have, in the last month, you need to have seen the minutes, and then airborne infection control must be part of that. Then facility-specific ICP plans, and it had to be visible. Risk assessments done in at least the last 6 to 9 months. Patient screening program implemented. Safe sputum collection areas, N95 respirators available, and fit testing done. Now on the N95 respirators, actually after we started the study, we should have actually set visible. So we had in the process 54 decentralized hospitals. We've assessed 24 community health centers and 50 primary health care facilities. Now the decentralized hospitals are mainly district and sub-district hospitals. So this was the results. Availability of ICP guidelines and policies, and the latest in almost all the facilities, but most of them within administration rooms and not really visible. Active ICP committees, 20%. Facility-specific ICP plans, visible, 25%. Risk assessments done in the last 9 months, 10%. Patient screening program implemented 50%, safe sputum collection areas only 30%, N95 respirators available, not used, 80%, and fit testing done 20%. So that is just a summary of what I just said. So on the findings, although the ICP guidelines are available at most of the facilities, they are not implemented. There's no ICP committees, ICP facility-specific plans, screening and triage being done, ICP assessments done, safe sputum collection areas, and N95 respirators. They are there but not used, and then poor infrastructure. So I'm going to say, I'm not going to talk about recommendations, so I'm going to say just a little bit on the interventions that we've done. I think this is a total new approach. So we did follow-up visits, were done, and on-site training giving on the implementation of the national IPC guidelines. So actually what we did is we took the guidelines there and we gave in-service training instead of classroom trainings. Workshops were held on the correct usage of N95 respirators, and fit testing, we've purchased fit testing equipment, and that was distributed to basically all the places that were ready to start. And then the nurses have to report on the fit testing done. Then sputum booths were built and tested according to the specifications set by the CSIR for safe sputum collection. And we are in the process of distributing these sputum booths. So we prioritize the sites where the sputum booths have to be, had to go to. Extraction fans were built, not bought, built, and tested according to the CSIR specifications on extraction fans. Installation is taking place at identified sites, and the provincial departments responsible for infrastructural development were trained on the correct installation and the maintenance of all the equipment. The same happened with the ceiling fans, where there's UVGI lights. And then we did a lot of support visits, and follow-up assessments are done to identify the sites. So we are in the process of the next round, and we hope with the next conference we will basically see what will be the outcomes. This is just some slides of posters, etc., that we implemented. Thank you.
Get your phone back. Our next presentation is Amanullah Moman from Afghanistan, talking about the exploring level of knowledge of healthcare staff on TB infection control measures in Afghanistan. Welcome.
Good afternoon. My name is Amanullah from
Oh, sorry.
presentation.
Sorry.
No problem. Don't worry. Today I would like to talk about exploring level of knowledge of health professionals on TB control measures and infection control measures in Afghanistan. We all know that hospital-acquired infection or a major public health problem, and WHO also, World Health Organization also prioritize addressing this infection. And adding to the background, I should say, the steps are taken so far in Afghanistan. Afghanistan developed the infection control SOPs and tools. So a major number of the health workers are trained, and some health facilities modified their and SOP was implemented. And beside that, this study was needed to explore how the knowledge and practice are there in place. The objective of the study was to better understand the barrier and help and guide the optimal implementation of infection control practices in the country, and to gather baseline information regarding the infection control practices. Here, the 15 provinces where this study was conducted, highlighted by 2 colors. The study was a cross-sectional study, 80 health facility conducted in 80 health facilities in 15 provinces. So the health professionals, nurses, lab technicians, and physicians were interviewed in 230 health facilities. Among the interviewees, 40% were nurses, 35% were physicians, and 25% were lab technicians. As a data collection tool, a standard questionnaire were used, and data analysis was descriptive statistics were used to assess the responses. And the study was conducted during January and February 2016. In this table, the results or finding of the study are summarized. The total sample size was it was 230 healthcare workers, and among them 70% were male and 30% were female. And among the respondents, 26% of the respondents, health workers, who believed on hand hygiene, and very low percentage, 7%, they perform regular hand hygiene prior to contact the patient. And 49% of the health workers had knowledge of TB. Over 90% of the health workers had knowledge of the TB. 71% of the of health workers, they have knowledge regarding acquiring TB from the patients. 92% of the health workers who engaged in TB infection control prevention measures. 95% of the health workers know that TB infection control measures can protect patients and clients. 50% of the health workers who know that ultraviolet lights can prevent TB, and 15% of the health workers who were respirators, or those health workers do look after the patients. As a conclusion, the message is there is a rising awareness among healthcare workers about the importance and proper practices, and also this increasing awareness combined with the improved hand hygiene may help improve patient safety at health facilities. And improved infrastructure is needed to promote TB infection control measures implementation. Enhance hand hygiene practices among healthcare workers are also recommended. Thank you.
Thank you very much. We'll take questions.
Okay.
A couple more presentations. So the next presentation will be by Gladys Kigozi from South Africa on assessing tuberculosis patients' knowledge, attitudes, and practice research to strengthen infection control interventions in PHC facilities. Welcome.
Good afternoon, ladies and gentlemen.
They'll get your presentations in the back. 1 second.
Good afternoon, ladies and gentlemen. My presentation will be about patients' tuberculosis knowledge, attitudes, practices, research to strengthen infection control intervention in primary healthcare facilities in South Africa. As we all know, primary healthcare facilities are entry points for care, treatment, and cure, but they can at the same time expose both patients and healthcare workers, especially those with suppressed immunity to tuberculosis infection. There have been specific TB infection control recommendations and policies that have been set for healthcare facilities and congregate settings, as well as households. However, patients may engage in high-risk behavior that is often linked to poor attitudes and lack of knowledge, which undermines the TB control efforts. Thus, it is always important to understand patient knowledge, attitudes, and practices so that you can prioritize TB infection control within facilities. Just to show you, this is a typical facility with where we conducted our research. So the objective of our research was to assess patient TB and infection control knowledge, attitudes, and practices in primary healthcare facilities. Our setting was the Free State Province. And the province is a Free State Province. I hope it is clear enough. And it is the Mangaung Metro where we conducted the study, with a population of about 2.7 million for the Free State Province, while the metro itself is home to about 783,000 inhabitants. Diverse languages are spoken in the metro and as well as in the province, and the TB incidence for the province was about 685 cases per 100,000 population. So we conducted a cross-sectional study across 40 facilities, and we sampled patients in proportion to the number that was registered. We conducted interviews in the local language of the patients and through informed voluntary participation. We collected data on demographics, patient knowledge, attitudes, and practices, both at home, in the facilities, and in the workplaces. We made composite scores of the TB knowledge, attitudes, as well as practices. And statistical analysis was descriptive, inferential, as well as multivariate logistic regression for determining factors associated with good infection control practice. The significance level was 5%. So in terms of patient demographics, we found that the median age of the patients was about 38 years. Most of them were female, and the majority were unemployed. The location of most of these patients, they were attending clinics in the urban centers compared to small towns. And we asked a question about information dissemination at primary healthcare facilities on infection control, and about 60% had received such information. In terms of TB, in terms of respondents' attitudes towards TB and their infection control practices, we found that the patients that were attending clinics in the small towns had more positive attitudes towards TB compared to their counterparts that were attending clinics in the city centers. And when we compared TB patients to the general patients, the non-TB patients, we found also that TB patients held more positive attitude toward TB than the general patients. In terms of factors that were associated with the likelihood to practice good infection control, that is hand hygiene, using of masks, and disposal of tissues into appropriate bins, we found that when we controlled for factors like age, gender, education, knowledge on TB, employment, receiving information about infection control from the facility, we found that being employed increased the likelihood of good infection control by 11%, while having received information from the clinic increased the likelihood of good infection control practices by 20%. And being a TB patient compared to being a general patient increased that likelihood of good infection control practices by 60%. So in conclusion, we conclude that dissemination of information on infection control is highly effective in improving patients' infection control practices. However, in our study, we found that 40% of the patients had not been informed about infection control at their facilities. TB prevention interventions at primary healthcare facilities need to address the misunderstandings that exist about TB. For example, in our study, we found that some patients, when we looked at particular knowledge, they were saying that more than 80% of the patients were saying that one can get TB through sharing of toothbrushes and through kissing. That is very, very, very risky. And then we propose that future interventions should target particularly the unemployed and the general or the non-TB patients. We have provided some feedback to the Free State Department of Health, and we are in the process of developing strategies to improve health education that will target misunderstandings towards TB and to improve the attitudes of patients towards TB. I'd like to acknowledge the Free State Department of Health, the participants, the National Research Foundation. Thank you very much.
Not least, I hope I don't mispronounce your name, Dirje Hapte, from Ethiopia, presenting on the instance of TB among healthcare workers at public healthcare facilities in 2 regions of Ethiopia.
Yes, thank you, Chairperson. I'm going to present about the incidence of TB among healthcare workers. As we work on TB infection control, we need to assess also how risky health working is in our setting and how many people are affected by tuberculosis. And it's a USAID-funded project, and we implemented our project in 2 regions of Ethiopia with a population of over 50 million. These are the authors and co-authors. As you all know, healthcare workers are at increased risk of TB infection compared to the general population. And WHO recommends, to compare health worker TB incidence versus the local population incidence. And in our setting and in other settings too, TB surveillance among healthcare workers is poorly practiced. And it's not one of, the reportable indicators in our health information system. And our objective was, to investigate whether or not our healthcare workers are at increased risk of TB incidence as compared to the general population. We did a cross-sectional study. In our project, there were 64 hospitals, and we covered 60 of the hospitals because most patients are, getting care in the hospitals. But we also did, our study in 11 health centers with high patient load, and to see, if the health centers also are having higher risk of health worker TB infection. And we used a structured questionnaire on TB-IC, and we obtained, the number of health workers who had TB disease in 1 year, over 1 year. It's not, individual level survey. It's a sort of health facility survey to see how many health workers were affected, in 2013, 2014. It included both clinical and administrative staff, and unfortunately, we don't have the disaggregation for the clinical and administrative staff to make further comparison. And we received ethical approval from the Regional Health Bureau. So as I informed earlier, there were a total of 71 facilities, most of which being, hospitals. And over 1 year, there were 70 TB cases that were reported in the 71 health facilities. And there is a likelihood that, there is underreporting. Not all health workers get TB treatment in the health facility they are working in for the fearing stigma and discrimination. So we suspect that it's an underestimation. And out of 71 health facilities, health worker TB infection was seen in 29 of the health facilities, which is around 40%. And if you can see the bullet somewhere here, there are certain health facilities who have more incident cases than other facilities. And we found out that there were 8 incident TB cases in 1 year in 2 hospitals, and 6 incident TB cases in 1 hospital, whereas we have around 41 health facilities without any TB infection. And all the TB cases were treated according to the national guideline. Just to highlight, the number of TB cases per year, in 26 health facilities, there were 1 to 4 health workers were diagnosed with TB and put on treatment. In 1 health facility, there were 6, and in 2 health facilities, there were 8. And the overall incidence of TB among healthcare workers in the 71 health facilities was around 460.3 per 100,000 per year. In conclusion, the incidence of tuberculosis was higher as compared to the national incidence in our country, which is 207, which is 2.2 times the TB incidence in the general population. And we recommend, a routine screening system and medical checkup in the health facilities. It was only 1 health facility that was having regular health worker screening for tuberculosis, only 1 out of 71. And we recommend, a regular screening as was stipulated in our national guideline. In our national guideline, it states that there has to be at least once a year health worker TB screening, which we didn't find in our survey. And further investigation is recommended, to assess the high infection rate in some of the health facilities. And we are also planning to have individual level survey to see the risk factors like diabetes, HIV status, history of, attachment in some of the TB clinics, things like that. So we are planning to have individual level survey to assess for possible risk factors. Thank you very much.
So that brings our presentations to a close. So now we can open the floor to questions on any of the presentations presented today. So there's a microphone there, although we're also a small room, so you may not need to use the microphone, but please feel free to ask questions. Please come.
Daniel
Thank you,
Shemtop
Dan.
from Jerusalem. I was in WHO before on TB infection control. So thanks a lot for many of this presentation. I was particularly interested by your presentation in India. And definitely this kind of assessment is very helpful. I would like to ask, what are your next steps in your facilities? And I have almost a similar question also for you in South Africa and so on, but very good work done. What next, please?
Thank you very much, sir. We have started with the recommendations, and the first thing was trainings. And we have conducted trainings for all the 30 centers, critical staff nurses, as well as pharmacists and medical officers. And we have also done online trainings. Now, the second step is we have designated officers for the each and every ART center. The ART center's nodal officer is going to follow up on all the recommendations. And the next step is, like, we are planning to have follow-up assessments on the observations and how much they have been done. This is in short, but the critical gap of training is now addressed, and the procurement of N95 respirators as well as the mask is inbuilt into the procurement mechanism of the facilities.
Can I just complete? Just to focus and to emphasize, maybe you had the opportunity yesterday to be in the Global Fund meeting, just asking, I don't know if you were in the morning, but the emphasis and possibility now to use the next year and a half to have more procurement And definitely one of the things that you show in your assessment is the lack of a lot of. So maybe you will have now the possibility not only to make training, which is important, but cheap, but also to use money, available money from Global Fund to have some investment. So just to re-emphasize what was said yesterday and by Global Fund.
Thank you.
As I said, we are busy with decentralizing MDR-TB and implementing nurse initiation treatment. So basically, no one of the facilities can start with the initiation of nurse-initiated MDR-TB or decentralized MDR-TB care if the basics are not in place. So from the facilities that we've assessed, there was quite a lot of them that that could not start. So what we did is we started with the trainings, the in-service trainings, and then also a lot of these facilities, the infrastructural, it's basically infrastructural problems, and that is why we prioritized. So we received some PEPFAR funding, and then the CSIR built we have about 12 of these mobile sputum booths that we built, and that we basically prioritize the facilities that they are going to. They've already started with that. You know, we have, for example, one decentralized site where the MDR-TB unit is on the 3rd floor, and they give sputum in the toilet. So those are the things that we have, and that is why we prioritize that. Then, secondly, we have the infrastructural infection control courses and with the CSIR. So we are actually investing a lot on infrastructural problems, etc. at this stage for the ventilation and for those. We are in the process to do follow-up visits to those places that has not been, the infection control is not correct. As we do follow-up assessments, there's already, we can see a lot of improvement. And I think the fact that we do the on-site training on the, and I will recommend this on-site training on your policies on site instead of classroom trainings definitely makes a difference.
Thank you. And then, sorry, then there was another hand up over there. It's okay, perfect. Go. You can go ahead since you're up, and then he'll be next.
My question, actually, clarification go to the the presenter from Ethiopia. So, you know, I noticed from your slide, the slide for the result, saying that like 29 health facility have at least one healthcare worker have the TB. So from that result, I noticed that the health facility, the 2 health facility, which have more than, we have 8 TBK. The number of the health worker in those 2 health facilities is 1,400 health worker. But like for all others of health facility, the average of the number of workers per facility is just over like 200. So I think that maybe like the 2 facility which have 8 TBK maybe like a tertiary hospital. So that's why they have a large number of healthcare workers. So my question is that, like, do you have any kind of like classification of the hospital? You do the questionnaire, like because like the patient who visit the different kind of hospital will be different, like the tertiary or the or the lower level of the care, the hospital or the healthcare center will be different. And also, like, if you have looked at the type of the hospital, whether or not like you include in the 71 healthcare facility, include only the general hospital, or also the chat or the TB household? Thank you.
I think I take it as a comment, but in the last column where I presented, it's not the number of hospitals, but it's the incidence within those two hospitals, okay? Yeah, that one.
So this one is a number of health workers.
Yeah, that's right, yeah.
1,400.
Yeah, that's right.
Facility.
Yeah,
So it's more than 700 healthcare workers per facility.
that's
But
right.
for other facilities, it's over 200.
That's right. But when you compute the incidence, you know, the denominator and the numerator, yeah, we did it that way.
Okay, with the incident. But I think that, you know, with the different scale, the number of the healthcare workers, the scale of the facility is different.
That's right.
Yeah. Maybe like for the facility with like more than 700 healthcare workers, that is maybe like a very big household.
Okay.
Maybe a tertiary household.
Yeah, what we did was actually we visited some of the hospitals. One of the hospitals who reported 8 facilities, they have poor infection control practice. And we did, you know, focused intervention on those facilities. So those facilities with higher number of TB cases, we did investigation, further investigation, and, you know, we built their capacity, and for some of them, you know, we modified the windows and things like that. So we are addressing those hospitals and high load facilities accordingly. Thank you.
If I can just, that was my question for you, if you did, for those that had higher numbers of cases, if you had done any investigation and what you found as to why the incidence may have been higher in those hospitals and what interventions you put in place to address that.
Yeah, if I can cite one of the hospitals, not only, you know, administrative staff, even a medical internist was affected with tuberculosis. And most of those people, they are working in the medical wards and in the outpatient clinic. And when we assessed, you know, there were very poor TB infection control. Windows were not opening, actually. There's only one way, a door, and there is no ventilation. And they were not also much aware about, you know, TB infection control practice. At least they could have done, you know, the minimum protection. So what we did was we made an assessment, and we built their capacity, and we are visiting those facilities every quarter. And the other thing we did was we discussed with the regional health bureaus about the seriousness of the issue, so that, you know, future plannings, even newly built hospitals are not having, you know, standard TB infection control, friendly infection control buildings. So we are negotiating with the engineers about the importance of TB infection control.
Okay, great, thank you. Yes, sir, you've waited patiently.
Where these health workers were working in these health facilities, but the other one is for the decentralized program in South Africa. What community level TB infection control interventions do you have?
At this stage, we haven't got community infection control preventions, but with a new grant, the new Global Fund grant, we will have a community infection control program. So it is part of that, and we have a target. So what we will do is, with the CSIR and the Department of Health, the minimum equipment that needs to be in that specific kits will be distributed, and then training will be given to the households. And then we will definitely, part of this whole process will be data collection to see what is the effectiveness. They've already piloted this program with some other external funding in one of the provinces within South Africa. So this is going to be a new thing for us.
I see you, Daniel, but I just want to see if there are any other questions before Dylan.
Another question for South Africa. It's a 3-part question. First part, I'm wondering if you, when you were developing your tool, your assessment tool, the multi-indicator assessment tool, was that something that was homegrown, or did you look broadly through the literature to see if there was how did that come about? B, do you have any thoughts about creating a standard tool to assess across multiple locations. I think that's something that we need. And then finally, when we talk about the use of the personal protective equipment like a N95 respirator, we can ask yes, no, are they available? But I think the use of the respirator is really, it's how it's used. And so curious as to your thoughts or other people's thoughts about how we can assess the efficacy of the respirator, how it's being used in terms of hours, in terms of whether it's applied. Do you look at the number of people who are using it correctly versus total number? Thoughts like that.
Okay, the first question on the assessment, so we basically used the WHO guidelines and we adapted it to the conditions within South Africa. And then the tools that we develop, we have the CSIR, as I said, they are the experts in South Africa and they are working very close together with the Department of Health. So they've actually developed an electronic tool where one for tertiary hospitals, one for decentralized hospitals, and one for primary health care facilities. You can't, out of experience, you can't really use the same, exactly the same one for hospitals and for primary health care facilities, because if you look at, there's a lot of things that differs. One of the things that we've seen on the assessment was that most of, especially hospitals, they do have infection control programs. But when you look at the minutes, there's nothing on airborne. Mm-hmm. So they have active committees, but no airborne infection. While if you go to the primary healthcare facilities, in those places where you do have the active committees, they actually always, most of them, are addressing the airborne infection. So even your approach on training will differ. On the second question is, we work together with the CSIR and one of the N95 respirator companies. So we bought a lot of fit testing equipment, the sour and the bitter, that one. And we've trained we've trained the facility. So in each one of our districts, there's at least 2 of these equipments. So the only challenge that we have is that, I think we need to train the procurement people, because what they do is they basically buy, number one, the cheapest. Mm-hmm. Not all of them are N95 respirators. I have a whole box with all kinds of respirators where it's N95 and no specifications on that. And the second thing is they buy one size. Mm-hmm. So you can do fit testing, but then there can only be mediums or one type of. So what we've done that, as I said, we received some PEPFAR funding. So what we did was, but it's not enough, but we bought, basically from 2 different companies, we bought all 3 the sizes. And as we go along and we do the decentralization where there's no respirators or they can't use that, we will distribute limited ones to that. But it's only once of funding that we got. But on the N95, on the respirator, on the training and the usage of that, there was studies done by the CSIR, and basically when that elastic band is not working, that is the main issue, that they can't use it. So what we do in the training is basically train the people to correct fit them, and then also how to, if they are not using them, you can't walk with it the whole time, is to basically how to protect them. Your brown bags, and then even looking after the elastic band.
Can I just one follow-up?
Yeah.
Thanks. Do you think it's possible, though, to characterize the use of N95s as a way to judge a facility on its, its infection control policies? Like, do you think it would be helpful to look at how healthcare workers are using N95s as a rank of, this is a facility doing a good job with infection control?
CSIR in South Africa, they are doing that, but I think the main thing is, number one, dedication. Number two, there's hospitals where you have all the equipment available, and you have all these activists protecting doctors, etc. But when you go to the facilities or whatsoever, they are not using the respirators, and then if one or two doctors are getting sick, then suddenly the whole hospital starts wearing it. I see a lot of people that's nodding and laughing. So, we try our best, that's what I can say. And we are implementing a lot, try to implement. But first of all, you need to have the dedication, you need to have, we've also seen that if you have a very dedicated manager, then everything works. If you haven't got a dedicated manager, nothing works. You can do whatever you want to. So,
Grigori, if you want to respond to that. Sorry, he was. Okay.
So I have a question for South African presenter. I'm Grigory Volchenko from Russia. Did you assess the impact of the decentralization of MDR-TB care on transmission risk in the community? Does your plan to implement special kits for patients means that the risk have been increased actually? So what? And excuse me, one more question for British presenter, if I can. What's your next step? Do you plan to somehow verify your data in, for example, transmission risk in churches? Is the risk for the servants, people who stay longer in churches, is really higher? Is there incidence increase for churches? Thank you.
I'm not 100% sure on the question.
My question is, what was the impact of decentralization of MDR-TB services on transmission risk in community for family members and so on?
Okay, as I'm saying is that at this stage with MDR-TB, we haven't started yet with community programs. Okay. Then secondly, I think as with any other TB, you have your basic education, health education that is part of your infection control and protection. Whether the people are implementing in the households is another question. So I know that we are waiting for the data of the project that they did, that they are basically have implemented in Eastern Cape. The data is not yet available. I was part of that, that's why I know. But we hope that it will definitely have an impact if you train. And that is why I said that we will have definitely very good data to see what is the impact of that.
Okay. Thank you, Aniki. She's just going to respond to Grigori's question.
So the next steps of this work is actually mathematical modelling to address some of the kind of limitations I brought up with regards to moving from this contact data onto actually where transmissions occurring. In terms of testing it, it's been hard to tease out. People will have different levels of risk from different locations. So they may be at high risk because they go to a church a lot. Someone else will be high risk because they go to bars a lot. So separating that out will be quite tricky, particularly because it's also quite stochastic. If someone happens to go to a location where someone who's very infectious is that week, and that will put them at higher risk, even if in general they don't go to high-risk buildings.
Can I ask a follow-up question to that? You showed a high amount of contact with children in the workplace, and so I was just wondering, which seemed surprising, so I was just wondering, were those teachers, were those healthcare workers, like who were what was the, if you can squeeze that out from the data of who these children were in the workplace or how that contact?
Yeah, no, unfortunately that data is not really there. I mean, there was limited qualitative data collected on occupations, so no, it's not really the teachers, it is other, well, I mean it is, but it's also going on in other workplaces as well. So from this data set, no, I can't say, but I am doing a follow-up study collecting more contact data, and that is something I'll look at.
Okay, great. Is that Jürgen Spector? And then Daniel will come back to you.
which is the comment, first of all, my colleague from Ethiopia. Thank you so much for the highlighting on the TB and healthcare workers. I think it's very important. Just general comment that I think it's important. Just this risk is just becoming more and more evidence to ground. There's a risk for healthcare workers to get TB, and I think it's important that we maybe consider. And we've discussed it in the previous meeting, but maybe consider if, inserting that in registers, because some countries don't have the capacity in occupational health to follow up these cases, and perhaps just from a country level start doing some proper surveillance on this so we can proper data on TB and healthcare workers, and not only find these cases during meetings or maybe certain publications. It's just a suggestion, an overall comment. And then also, your presentation was very good. Thank you so much. But I also think, just in terms of not only modeling, but because that becomes more theoretical, but also in terms of practical, our colleague Dylan over here is heading the FAST strategy also globally, and the presentation by Bangladesh was very, very good. But I think, innovative strategies such as what's happening with FAST in the healthcare setting should maybe be implemented in places like the workplace, if we know, or maybe Shabeens or taxi ranks, where we know there's going to be more actual transmission taking place as well. And the last thing, just in terms of FAST, and I don't know maybe whether Dylan or maybe a colleague from Bangladesh can answer that. From the data we've seen, there's a recent systematic review done to show the amount of mortality or amount of TB that's found post-mortem in HIV patients, implying basically that we are struggling to screen, identify patients with TB that's HIV positive. So we implement a FAST strategy in populations with high HIV burden. How are we going to approach that and making sure that we catch those patients as well? Would LAM, determined Levy Lab, would that be a strategy combined with experts maybe in terms of screening stage? I don't know whether
in the interest of time, since we're over, I'll let Daniel, because he's got a burning, sounds like he has a big question, and then we can
I would like to
discuss
re-emphasize the issue that you brought about the healthcare workers and your question. I think it's a major issue. When I was in WHO, we put a lot of energy trying to have an indicator. What will be the efficacy of infection control? And by the end of the day, we produced a document with a TB cap, and we agreed on that the only real measurable and quite objective indicator would be to look for healthcare workers' TB cases. And because having only looking for efficacy about this N95 or this, it's too small. We would not have any proof of concept.
And not the most effective.
However, if the people implement at the healthcare setting correct a series of measures, the impact will be most probably first to the patient, but this will be very difficult to measure. To measure in the healthcare worker, this would be much easier. Because of that, what you did, it's very nice, and I really appreciate, and a lot of things to think about and to continue.
Thanks, yeah.
Thanks a lot.
Yeah. We're over time, but I think that we've had a very good, thank you for all of the speakers for keeping to time, which allowed us to have a nice long discussion. I still have more questions, and maybe some of you might have more questions to follow up on later, so feel free to stay around and continue to ask questions after. But thank you very much. It was a good range of topics on strategies to increase detection of TB cases, healthcare worker safety, which is my passion. So thank you all very much, and enjoy the rest of the last day of the conference.